we started the show with you. You've had a little time to kind of sit back and watch what we're doing here. Tell me what's on your mind.
Well, I think one thing that we haven't talked a little bit too much about is mental health. And I think that's one of the things that we have to be cognizant of. And I think that's another issue that primary care physicians don't get a ton of training about. I know there's a lot of reticence to talk about mental health and the stigma attached to it. But I think that's an issue that could probably be brought up a little bit, especially with the stigma and things like that associated with it.
In treatment, we find at Bridgeway about 7 out of 10 clients that come in for substance abuse treatment also have comorbidity. And interestingly enough, with adolescents, that number actually seems to be also on an uptick. And I don't know if that's because people are diagnosing better or there's just more prevalence to it, but as it relates to substance abuse, when you find something that's at 70, 80% of the time, that's definitely something that needs to be addressed. I think the treatment of it has improved. Chad was speaking to it a little bit, and Karen definitely spoke about it earlier. But the Children's Service Fund and all of these providers are providing treatment to adolescents here in St. Louis County. And what's so important about that is it needs to be solution-based. We can talk about it from a criminal justice perspective, or that somebody is wrong, or the stigma that's associated with it. Once it becomes public health policy, that stigma can just, when I was thinking over there was, when a person gets diagnosed with cancer, the immediate conversation becomes treatment and only treatment until that treatment works. That is not the case as it relates to chemical dependency or mental health issues. It relates then to a stigma that's associated with it. There's something wrong with that person, and then the symptoms are what gets focused on, not the solution. So the solution for chemical dependency specifically is treatment. For abuse, I would say education or prevention, but also treatment for that as well.
I would add that even before treatment is screening, and there's so much time invested in screening people for their cholesterol level. And everybody even knows what their cholesterol level is or how often they're supposed to check their cholesterol. But who cares what the cholesterol level is if they're addicted to alcohol or opioid pain meds?
I mean, I have a disease that you can't detect. It's like a pain analogy. Until I take pain medication, irresponsibly become addicted to it, whatever is my path, that's when I'm going to cross the line from abuse into addiction. So it's kind of hard to catch that before it starts. Prevention, education, solution, once that happens, but there's no real way to predict when and who is it going to happen to. It's
So we have a screening tool called SBIRT, which is screening, brief intervention, and referral to treatment, but it's going to miss a lot of folks. And so I've been fully trained in practice for 11 years, and the times in which I have missed something, or I have been burned, I have not served a patient, is when I miss substance abuse. And I go back and I look at that first note, and I definitely asked a really good med student history, and they said no. And it's only as a maturing physician that I realize that it's only after they trust me for a few years that you ask and you ask again.
And it's hard too. I think pharmacists can be a step in that to catch that early, but again, we don't have the monitoring, and so is this prescription from across the river in Illinois or Kentucky legitimate, and they're here visiting a family, which could be very legitimate, and you don't want to refuse pain medication to somebody who really needs it. But as a pharmacist in the pharmacy, we don't have that network and that ability and to notify the physicians and to really have that teamwork approach to addressing this early before it becomes a bigger problem.
Just one back to what you just said. The reason why it takes me time to trust you to answer that question correctly is because I have been taught since a very young age that since I'm addicted to drugs, there's something wrong with me. If you ask that same standard medical question for cancer, diabetes screening, you're going to get a straightforward answer right off the bat. It's going to take years of trust for me to actually admit to you, yeah, I have a problem. That's because in my brain, because of what has happened in my life and what I've seen on television, what Dare taught me, things that I do drugs, I'm a bad person. That is what is killing people and also needs to change. We need to remove that from the society. I mean, it's an impossible task, but we have to try something because it's killing people.
I lie to you about how much I even exercise. So. It's not 3 to 4 times a week.
Maybe I was a little
more of a goal.
More of a guideline.
What I'd like to be doing, not what I am. Yeah.
This end of the table often gets shut out by the ergonomics of design here. Joe, what should I have asked you over there? What's on your mind?
Oh, I just think people need to realize that in today's heroin world, they don't realize what they're getting. Kids have no idea what they're getting. They're getting it in a pill form. They're still ingesting it, or they're using it as a needle. But the purity, heroin purity today is 90%. Back in the 60s and 70s, it was 10, 12%. It's so much stronger now, and these kids have no idea what this is doing to them.
And we didn't really talk about that tonight, but that's how people overdose. Is that right? I mean, because it's different. Like one particular amount got a particular amount of high one time, and that same amount, if it's cut differently or have a different purity, will kill you.
And what is happening is these kids are trying it, and they're getting that big shot from the dealer. Then when he starts cutting it, they start realizing what's going on, so they go find a new dealer. The new dealer gives them a big shot again, and boom. It's attacking the respiratory system, and they're just shutting down. And my son was 90 days clean when he relapsed.
Let's talk about that. It's where I want to know, and maybe you can help us here, the status of something like Narcan and the PDHP. Did I get the acronym right? PDMP, sorry.
The status of Narcan, from what I understand last week, is that it's dead for this year. We have 2 weeks.
No, Narcan actually passed out
Just
the Senate
yesterday.
last night.
Yes.
Oh, did it?
Yes, it
Well,
came out of the Senate last night. Currently, it's on its way to Nixon's desk.
I wish we had a reporter here who would.
No, it was. Right. This was already.
Yeah, no, you're right.
Yeah.
The
It did
Senate-
pass out.
that is correct. I saw that
It
today.
passed out last night. This is for first responder Narcan. So what this is going to mean is that ambulance usually carry it, but firefighters, police are usually the first to arrive on the scene. So they're going to be able. This law.
I know that our county chief has spoken out in favor of.
No, he has. Now, what this law is going to do is going to give them the ability to carry Narcan. It's not going to require them to do it. So there's a difference between getting a law passed and implementation. So when and if Nixon signs this into law, the next step will be all of us and people in the community getting together to ask that their first responders start carrying Narcan. And this is just a piece, as we said earlier, of the harm reduction picture, which includes Narcan, 9/11 Good Sam, PDMP, other things to try to give people the most access to staying alive until they're ready to get help.
The 9/11, your reference you there is if you call someone's overdosing, you're not putting yourself at risk of prosecution.
You'll get limited immunity from prosecution for small amounts of possession. That bill actually died this year. We'll be revisiting that next year in Jefferson City.
Okay.
One thing seems clear tonight, I mean, from all these conversations, everybody's here, we all seem to be on the same page with the PDMP, that we've got to have this in this state. And so the challenge is, as I mentioned earlier, and I mentioned the senator by name for a reason. We've got this one obstructionist, and what are we going to do about him? You know, how are we going to get past this one senator who's filibustering and stopping this bill, this law that we need in this state?
Any chance of that happening this legislative session?
Well, I think that there still is. We have 2 weeks left, and and by all appearances, it's sitting in committee and is not going to come out in the Senate. However, we've been contacted by a New York Times reporter a couple of weeks ago. He actually showed up at the Capitol Monday, interviewed Dr. Schaaf, doing a very big story on Missouri, and he's down in the Boot Hill today meeting with doctor shoppers and folks that are addicted, and is going to try to bring light in the United States of what Missouri is lacking, and it's shameful. And I think that we need to get that word out, and he's going to help with that. And he's very fair. He's interviewing people on both sides of this, and gave Dr. Schaaf a very nice interview, and let him speak his piece about the privacy issue. I don't feel it's a privacy issue because, as the doctor mentioned, this information is out there. It's just in different locations. We just don't have the access to be able to be preventative of this.
And we're not getting reports from the other 49 states of abuses of this either. And I think that's a heavy indicator of the fact that it makes sense for
Excellent point.
Missouri also.
Yes.